So thank you very much for the introduction, Bruno, and then the invitation. It's a great discussion that has been going on, and I would like to finish with the medical oncology case. Now I can switch my slides also. So the case I would like to present is a 49-year-old woman, 49-year-old as of today, who was diagnosed back in 1988 when she was 15, just turning 16 years old, with a Hodgkin lymphoma of a nodular sclerosing type, stage 2B. That was in a supraclavicular lymph node on the left. She underwent the staging laparotomy and splenectomy, which were negative, and then received curative intent chemotherapy. At that time, she was living in Spain. So the chemotherapy at that time was MOP, a very old regimen, and a combination with ABVD, which we know and is still used these days. Unfortunately, she relapsed a little bit more than half a year later. And as a treatment for this relapse, she underwent percutaneous radiotherapy. That was done in Zurich, actually. She had moved in the meantime, and it involved the mantle field and the periaortal and inguinal lymph nodes. And that was done from November until January 1990. And since then, the patient is in complete remission. And just to remind you what that meant, this radiation therapy, maybe the radio oncologists can comment afterwards. So that's a screenshot from Wikipedia. And you can see that basically any lymph node station was irradiated at that time. Then 2 years ago, in February 2020, she presented with a refractory cough that had been going on for some weeks. She went to the family doctor and she underwent investigations using a conventional radiograph, then a CT scan, and that was also complemented with a liver MRI because there were multiple pulmonary and liver metastases in those imaging exams. The family doctor referred her to our lymphoma team, given that she had Hodgkin's disease in the past, and they performed a liver biopsy, and that's the pathology report. You can see here the H&E stain, and she was diagnosed with infiltrating metastases of a Leiomyosarcoma. The colleagues from pathologists thought that likely it was of uterine origin because she had an expression of estrogen receptors and progesterone receptors. So we also referred her to our colleagues from gynecology, but there was no evidence of a primary tumor in the uterus. So we were faced with the discussion of how to treat the patient. She had pulmonary and liver metastases, so palliative chemotherapy was of course indicated. And what would you choose in this situation? So we know that Doxorubicin mono is actually the standard for soft tissue sarcoma. The trial comparing it with Doxorubicin and ifosfamide was negative with respect to overall survival. And all the medical oncologists are, of course, well aware of the sad story of the combination Doxorubicin plus olaratumab, which showed very promising in the phase 2 trial, but then the phase 3 trial, of which I'm showing the results here, was negative. Now, there was a very interesting presentation by Peter Reichhardt at this week's ESMO Sarcomagist meeting, actually, whether still there might be instances in which you would choose a combination therapy as a first-line treatment for metastatic soft tissue sarcoma. And in particular, leiomyosarcoma is known to be responsive to a combination of doxorubicin and dacarbazine as a partner, not ifosfamide, as you can see here in this publication by D'Ambrosio and colleagues. So we sometimes take this into consideration if we need a tumor shrinkage. This was not the case in our patient. She presented with very little symptoms, so we went for a monotherapy. Now, you remember she had had anthracycline-based chemotherapy back in the 80s as part of her Hodgkin's lymphoma treatment. So we had her assessed very carefully by our cardio oncologists, and they basically cleared her for a treatment with liposomal doxorubicin. She only had a minimally reduced ejection fraction. So we started her on Calyx as a first-line treatment. However, after 3 cycles, she had to be reanimated actually. So she presented with an ST elevation myocardial infarction in our emergency room. She went into ventricular fibrillation twice, had to be defibrillated and reanimated, and taken to the intensive care unit. She recovered pretty well from that. She has a reduced ejection fraction now of only 30%, but otherwise she recovered. And so here I put in a screenshot from Swissmedic Info, what is known about cardial side effects of liposomal doxorubicin. So of course we do observe a reduced ejection fraction, similar to non-liposomal doxorubicin, but it's much less frequent. And that's also why she got cleared for using liposomal doxorubicin. Coronary events are actually not described. We know that this can happen in platinum-based chemotherapy. It's actually not described in liposomal doxorubicin. So taken together, she had an ischemic and anthracycline/radiotherapy-induced cardiopathy. She had to be she had to undergo also implantation of an intracardial defibrillator, and that was done in February 2021. At that time, of course, we also performed a staging exam to see whether at least the therapy was doing something. She was stable in the lungs, but unfortunately progressing in the liver metastases. So we had to choose the next line of therapy, actually, in this difficult situation. What we did was we performed a comprehensive genomic profiling on a tumor biopsy. And then we routinely also discussed those findings at our molecular tumor board. What you could see was that the genomic findings, that the gene mutations were largely uneventful, so that didn't help us much. But what the bioinformaticians can also do is calculate the LOH score and other markers of HRDness out of those sequencing results. Now, HRDness, or also referred to as BRCAnesse, are basically features that can be observed in the genome as a consequence of mutations in genes involved in homologous recombination repair. And sometimes we observe those genomic features even in the absence of gene mutations. So the responsible gene might be inactivated epigenetically or for other reasons, but we do observe the phenotypic consequences on the DNA level. And that was exactly the case in this patient's tumor. So I had written here that the LOH score was way above the threshold, which is established for ovarian cancer, because in that indication, the test is approved. And also the large-scale state transitions were high. So that's basically, in simple words, the change between amplifications in blue and deletions. So if across all the genome, on all the chromosomes, you observe a lot of those changes, of those back and forth, you have a high value for large-scale state transitions, and that's another marker of HRDness. Now, Leiomyosarcomas and HRDness, there is data around. That's from a publication of Priya Chudasama and colleagues from the Master Consortium in Heidelberg. And they observed in a high percentage of Leiomyosarcoma samples signs of HRDness, be it that the HR genes are mutated, or be it those genomic biomarkers that I've just explained. And in fact, they have a trial recruiting, the TOPAR trial, in which they combine Olaparib plus Trabectedin and randomize it versus physician's choice. And patients can be enrolled in this trial if they have a high TOPAR score, so if they show signs of HRDness as assessed in their program. Now, for our patient, of course, that was not an option. With her reduced heart function, she wouldn't be eligible for any clinical trial. But we managed actually to convince the health insurance company to pay for a trial of this combination. Because there is some data out already. That's a screenshot from the phase 1b TOMAS trial, in which the tolerability of this combination in a classical dose escalation design was tested, and they also observed some responses, several actually quite long-lasting responses. So we started our patient on this combination. We did a 4 weeks run-in of the PARP inhibitor alone, and then started with the combination. On the first restaging in December 2020, she had stable disease, which turned into a partial remission in the next restaging, which was done in March 2021. And she has been in partial remission until December 21. And currently she is slowly progressing in the lung. I'm still waiting for the liver to be staged, because we're always doing this using an MRI. And for this, her intracardial defibrillator has to be switched off. So there's quite an organization around that, and the MRI is to be scheduled. But that's actually one of my questions now for the panel. And I would like to start the discussions with some questions. One question would be, in case she really is progressing now, what would be your next choice? Pazopanib is an option, but I've shown you her heart function. I would be very reluctant to use an anti-VEGF compound actually in this situation. Combination of gemcitabine docetaxel, but also there, is she fit enough for that? Dacarbazine mono, what would be your bet? And then we might also discuss the choice of first-line chemotherapy. So, of course, in hindsight, we would probably avoid the liposomal doxorubicin. Would you have started with gemcitabine docetaxel? And then maybe the panel would also like to comment on HRDness as a feature in the Leiomyosarcoma. Do you test for it, and do you have any experience on exploiting it therapeutically? And with this, I would like to conclude. I'm looking forward to the discussion.
Great, thanks so much, Christian. Awesome. Maybe I again pass on the questions to Joanna, Emanuela, and of course Axel and Jean-Yves.
I will mention briefly that we are now enrolling patient in the TOMAS 2, and I confirm that Leiomyosarcoma is an excellent responder to that combination, which is also feasible in elderly patient with some Olaparib holidays. And for the question of relapse, the carbazine monotherapy, also gemcitabine monotherapy, I think, and maybe Trabectedin, there would be also all reasonable considering the comorbidities.
Maybe.
Thank you very much.
Sorry.
Joanna, please.
Okay. Maybe I start with a comment on the first line therapy. You started with Telix. I would have done exactly the same. I have many patients that had other chemotherapies before have been diagnosed with a soft tissue sarcoma. And we use Telix in those situations quite often, and I never did see any cardiac complications. So this would have been my choice too, because the toxicity is also lower than in docetaxel and gemcitabine when it's combined. And regarding the next question, how to proceed now? Of course, you're right, the cardiac function is decreased of the patients, so I wouldn't go for a combination. I wouldn't also go for gemcitabine and docetaxel because it's really hematotoxic, and the patients would have to be in a really good condition and performance status to be able to get this combination. So from these 3 opportunities you gave us, I would go for the carbazine, maybe in a reduced dose of 850 milligrams per square meter in this case.
Okay, thank you very much for the comment on the calyx. That's very comforting, very reassuring for the next patient coming in, you know.
Okay, thank you.
Axel.
It's a nice case. And one important message, and when you take charge of a patient having a second cancer, even 30 years later, or patient for Hodgkin disease, leukemia, whatever, radiation therapy, the we have to be careful when we start anthracycline, whatever, even other drugs. In all my experience, when you start normal dose first line, even 30 years after an ABVD or MOP or whatever, you have toxicity, whatever the drug you use. So we have to be careful when we start systemic treatment in this situation. The second point is we are clearly in palliative situation, so we have to be in favor of monotherapy, sequential monotherapy, so like dacarbazine alone, gemcitabine alone. Also, estrogen, anti-aromatase or whatever, 5 to 10% of leiomyosarcoma in women have positive estrogen receptor. And in maintenance therapy, after chemotherapy or even in case of slow down progression, I use frequently Femara, or even it's not uterine leiomyosarcoma. So in each time we have a leiomyosarcoma here in Gustave Roussy, non-uterine, we test immunochemistry, estrogen receptor status, And don't forget the oral cyclophosphamide. There's a publication of MIA in 2016 or maybe before. 5 out of 6 radiation-induced sarcoma respond very well in frontline with oral cyclophosphamide.
Thank you. Thank you so much. Jean-Yves, do you have some comments to share? We don't hear you.
Yeah, I think what is important to have in mind is that probably when we are speaking of leiomyosarcoma, we are speaking of very different disease. Of course, the GYN and all the rest. We now are observing major differences in the molecular alteration which are observed in GYN and soft tissue leiomyosarcoma with different type of response, and the quality of response to each individual line is probably a topic which deserves to be investigated further. We had some strange observations, in particular the presence in a patient without family history of BRCA2 mutation, which seems to be somatic, which responded beautifully to a PARP inhibitor for a long period of time, and several observations like that of scattered molecular alteration, which can help to guide the treatment. And track alteration are examples which are well known. And also probably something on immunotherapy with tertiary lymphoid structure, which are very good predictors of the response of this patient to immunotherapy, while the other really do not go very well. But I think for leiomyosarcoma, this is really a world which is opening with a variety of different molecular subtypes which need to be investigated further.
That's awesome. Any further comments? Emanuela, you are laughing. Still after nearly 2 hours?
Oh, Emanuela, we don't hear you.
I was laughing on the molecular classification, because, which of course I agree, and I was really surprised because in this case it was performed, and the patient was actually receiving a PARP inhibitor of trial, and I think this is fantastic, and the effort of the oncologist should be underscored. I mean, based on a molecular alteration. So I think that yeah, in when it will be feasible for all patients, we know with the funding it will be easier maybe to have an algorithm of in order to have more active and more cheaper options. So
actually, we try to convince our health authorities that it's cheaper to do well, doing molecular analysis up front and then guiding the treatment. But we have not been succeeding so far.
Well, okay. I think this brings us to a conclusion. I would like to take the opportunity to thank you all for, of course, your time. Also, the presenters for preparing all these cases. There's always a huge effort to go in, and to everyone, not only the time but also sharing your experience. I think it's a really very nice way how to exchange informally. I think we all can learn. It's a great addition to our daily interactions. With this, having said that, feel free if you want to present case in the future, just let us know. Everyone has opportunity. I think we all can learn from each other. We want to foster that. We also want to foster the exchange of the disciplines. I think we saw tonight that this is really nice to get the perspectives of the other disciplines, not that we are just remaining in our silos. We have a next webinar in a month, which is listed here. It's the Jay Wonder and the Toronto group, actually. We will also start this format to not only have one presenter, but just the whole interdisciplinary group to share their experience, and then we can all benefit from that. Having said that, I wish you a very good evening, a good week.